Hello, everyone. My name is Tomas Hajek. I am a psychiatrist working at the Mood Disorders Clinic at Dalhousie University. And I would like to talk to you about a very clinically relevant issue, in particular weight gain. And I would like to focus on one research finding that made me rethink the way that we use antipsychotics in clinical practice. So I have no conflicts of interest to disclose and no interest in conflicts either. Obesity is one of the main public health concerns globally, and we can cite many striking and dramatic statistics regarding obesity. To me, perhaps the most striking one is that most of the world's population currently lives in countries where more people die from obesity than from hunger. This is the first time something like that's happened in the history of mankind. Now, obesity is especially frequent in people with severe mental illnesses, and globally, about 25% of people with SMI suffer from obesity. In some countries, including Europe and North America, it's actually 1/3 to even 1/2 of individuals with SMI who have obesity. And the relative risk is quite increased. People with bipolar disorders or schizophrenia have about 3 times greater risk of being obese than the general population. Now, this obviously has an impact on the physical health of our patients. Most people with, for example, bipolar disorders die from cardiovascular reasons, which can be directly linked to obesity. So the comorbidity with obesity leads to increased mortality and shorter life expectancy of our patients. It also, psychiatry is one of the fields where the mortality gap of people with psychiatric illnesses is not shrinking over time, but it's actually growing. And that's mostly because of the cardiovascular reasons which are related to obesity. Now, obesity is also more directly relevant to psychiatrists because it's associated with worse psychiatric outcomes, worse psychiatric prognosis. It's also associated with some intractable complications of psychiatric disorders, such as cognitive impairment, which further then contributes to the potentially catastrophic consequences, such as disability and suicide. And more recently, we're discovering that obesity markedly contributes to brain alterations in people with bipolar disorders or schizophrenia. So for all of these reasons, obesity is not just an issue for internal medicine, but it is undoubtedly and clearly an issue for us as psychiatrists. Now, there are many reasons why obesity is so disproportionately represented in people with SMI. But prescription of medications is perhaps the only risk factor for obesity, which is fully under our control. Now, I'm saying prescription is fully under our control. It's not under our control that the patient actually take those medications or not. But this is something that we can control better than any other risk factor for obesity. Now, the information that we know about what antipsychotics, for example, do with weight in general clinical practice is quite limited because the regimented clinical trials, systematic clinical trials that we have, they don't represent the messy everyday clinical practice. Also, if you want to really learn about the development of obesity and potential means of preventing it, we have to study this in people who are early in the course of their treatment and their illness, and studies in the first year of treatment are underrepresented. When we do have naturalistic studies in outpatient settings, they usually cannot guarantee compliance. They also have a hard time precisely quantifying the daily medication use, and they cannot standardize lifestyle factors and can be confounded by substance use. So to address these knowledge gaps, we recruited participants from general psychiatric hospitals to represent everyday psychiatric practice. We focused on people with first episode of psychosis to limit past exposure to medications and to explore options for prevention. And we focused on inpatient setting where we could maximize compliance, which allowed us to precisely quantify daily exposure to medications, and which also allowed us to standardize the diet and exercise and limit substance use abuse. So more specifically, we recruited individuals between 18 and 35 years of age who were undergoing their first hospitalization for a diagnosis of psychotic illness, according to the ICD-F20 and F23X. And they had less than 24 months of untreated illness. Now, the largest contributing hospital was the psychiatric hospital Bohnice, which is on the picture in the corner. This is a hospital that has over 1,200 beds and a catchment area of over 1.5 million people. This study kind of built on the infrastructure put in place by the early stages of schizophrenia study in the Czech Republic. And so as a part of the ESSO study, people who are hospitalized, among others in this large hospital, underwent a research visit during their hospitalization. Now, I asked my student, Dr. Vochoskova, who is on the picture down here, to actually collect day-to-day medication information from the charts so that we could have exact quantification of daily as well as cumulative medication exposure, and to also collect information about the participants from the admission to the hospital. So this provided us with some unique insight into how these people are treated in a large naturalistic setting. Now, obviously, this is everyday clinical practice. So there was a broad use of a wide range of antipsychotic medications, and because some medications were used more sparingly than others, we could not really effectively compare medications against each other. So for statistical reasons, we had to create larger subgroups. Now, to do that, we ranked medications based on their metabolic side effects. And to do that, we looked at the network meta-analysis, which allow us to pit medications against each other. And based on those, we grouped the medications into metabolically more problematic, which contained olanzapine, clozapine, and quetiapine, and metabolically less problematic, which contain the rest of the medications. We also wanted to plot the trajectory of medication changes throughout the hospitalization, and we again based that on the ranking of medications. So here are a few examples. On the left, you can see someone who started on the 9th ranked medication, which was risperidone, and he or she stayed on the medication throughout the 35 days until the research visit. Now on the panel B, you see someone who started on risperidone, and then on the day 5, they added olanzapine to his treatment, and he stayed on the combination of risperidone and olanzapine until the end of this treatment. And so we plotted these points of medication use and change, and then drew a regression line through these. So a positive slope represented escalation of medications, whereas negative slope represented going from a medication that's more metabolically problematic to medications that are less metabolically problematic. We recruited 173 individuals with first episode of psychosis. 61 of them were medication naive. They were on average 25 years of age, and 68% were males. Now, during the average of 44 days between the admission and the research visit, the patients gained on average 3.5 kilograms of weight, which translated into about 1 point of BMI increase. Now, the most frequently used medications were risperidone and olanzapine. Now, almost half of the individuals had a positive slope of their medication trajectory. And mostly this represented a switch to a combination treatment, including a more metabolically problematic medication. Now, only about a third of the patients remained on monotherapy, and less than a quarter of individuals had a negative slope. That means moved from a metabolically more to a metabolically less problematic medication. Now, interestingly, there were no differences between people who had the positive slope and the negative slope in their baseline weight, in weight gain, age, or sex. These two groups of individuals differed in their symptoms, and such that the people with the positive slope had greater follow-up PANSS positive and negative scores. So our interpretation of that is that these were the people who needed the medications to counter more refractory or more pronounced symptoms. Now, there were 4 predictors of weight gain, of medication-related weight gain in this sample. It was the type of medication, it was dosage, duration, and baseline BMI. Now, greater medication exposure to those metabolically more problematic medications, including olanzapine, quetiapine, and clozapine, was associated with greater BMI increase, but only in those with lower BMI. So I will repeat that. If you look at the people who gained weight, it was the people who had low or intermediate baseline BMI. If you look at the people who actually lost weight, it was the people who had the highest BMI. Now, in addition, longer duration of inpatient treatment was significantly associated with larger increases in BMI and greater weight at the time of the research visit. Now, there was no association between the trajectories of medication use and weight gain. Interestingly, the weight gain in those with the low baseline BMI, it was not constrained only to people with who were underweight. It also included people who had BMI of less than 25, which would be normal weight. The weight gain in this group was quite pronounced. It was 7% of their body weight, and almost half of them experienced a clinically significant weight gain of more than 7%. Even more concerningly, within the 7 weeks of inpatient treatment on average, these people's metabolic profile at the research visit was comparable to the people who were obese from the beginning, which is not good. Our data add to the significant other literature and number of meta-analysis, which also suggests that weight gain early in the course of psychosis is substantial and fast. Now, in our study, it was maybe even a little bit higher and faster because these people were early in the course of illness, early in the course of treatment, and all were hospitalized. And also, mostly they had healthy BMI. And as we saw, baseline BMI was one of the strongest predictor of weight gain. Now, there were 4 main predictors overall: type of medication, dosage, duration, and the baseline BMI. In the short term, the switches or sequences of medications did not predict weight gain. Now, if you think about it, we don't have full freedom of choice when it comes to the type or dosage of medication, where we need to base this on response and the severity of the symptoms. Similarly, as these are mostly lifelong and chronic illnesses, we don't have choice over the duration of treatment. So there's not much we can do about that. But the baseline BMI, that is something that we definitely can monitor for and be mindful of. Yet that's really not happening in clinical practice. This is not by any means the first study that found baseline BMI, low baseline BMI, to be predictor of weight gain on antipsychotics. That has been shown in multiple other studies. And yet, key guidelines do not mention this. None of these guidelines mention this as the predictor of weight gain on antipsychotics. I think this is in part related to the fact that this finding is poorly understood. The general thinking on this is that, okay, well, this is constrained to underweight people and is actually beneficial for them to gain weight. Well, that wasn't the case in our study. It was not constrained to underweight people. It was included also people who were in the normal weight range. Almost half of them had clinically significant weight gain, and it was linked with HDL and triglyceride alterations. So this is not beneficial or harmless. This finding is also usually ignored in clinical practice. In fact, we teach residents and young colleagues to be especially careful when prescribing antipsychotics to overweight or obese individuals. And if you, again, look at that picture there, it would actually make equal or even more sense to be especially careful in prescribing weight-promoting antipsychotics to people who are of normal or underweight, because these people are at the greatest risk of gaining weight. And in these people, we can actually prevent obesity, and prevention is always better and easier than treatment. Another complicating fact is that it would be hard in some countries to implement this type of recommendation because insurance companies don't take this into account. In fact, coverage of medications with a lower propensity for weight gain in some countries is limited to people who already are overweight or obese or have metabolic complications, when I think these medications should preferentially be used in people who are of low or normal baseline BMI. So to conclude, switches of medications are very frequent, and in the short term, they were not associated with weight gain. Now, escalation of medications was associated with more pronounced symptoms. Likely, more refractory symptoms required more aggressive treatment. So this is pretty much inevitable in some people. We don't have much choice over it. Baseline BMI, type of medication, duration of treatment, and dosage predicted weight gain on antipsychotics. So if we carefully think about these findings and try to postulate some rational treatment suggestions based on those, then I think we could say that we should start with metabolically less problematic medications as first-line options in first episode of psychosis, especially in people with low baseline BMI. Now, we may need to change or add medications in people who do not respond to these medications, but at least we give more people a chance to prevent, delay medication-related weight gain. I'd like to thank all my colleagues and collaborators, especially Dr. Vochoskova and Dr. McWeeny, as well as many other friends and colleagues, and thank you kindly for your attention.